Hey, welcome back. Today we're going through the neuroscience of the cranial nerves. So, cranial nerve number 3 is the oculomotor nerve, and it's a somatic motor. It supplies the extraocular muscles of the eyelids and of the eye. It's also a visceral motor component where it will innervate the constrictor pupillae and the axillary muscles. So it enters the cavernosus sinus and divides into the upper and the lower division. Upper will control the levator palpebris superioris along with the superior oblique, and the inferior will be passing through the ciliary ganglion and the inferior rectus and the inferior oblique. So most importantly, it's responsible for accommodation in the pupillary reflex. It will move the eye up and down and inwards, and it raises the eyelid. So a lesion of the oculomotor nerve is going to cause ptosis, a lateral squint, mydriasis, and a dilated pupil. Cranial nerve number 4, the trochlear nerve, is also a somatic motor nerve. So it controls the superior oblique, so you kind of remember that as SO4. And it controls the intorsion, so rolling your eyes towards the medial aspect. It also controls abduction and depression. A lesion of the trochlear nerve the patient will not be able to look down, and there's going to be double vision because the eyes are not synchronized. So, if this person tilts their head to their left, their eyes have to rotate to the right in order to compensate. So, in the cranial nerve palsy, there is not going to be, if this person tilts their head this way, right, and they have a lesion of trochlear nerve of the left eye, this eye is not going to be able to rotate inwards. It's going to stay rotating outwards. So, in these patients, the patients can see clearly if they tilt their head opposite to the lesion. So, since this eye can't roll inwards, the head will be tilted that way. The 5th cranial nerve is the trigeminal nerve. It's responsible for both sensation and motor functions. The primary sensory nuclei is going to be in the pontine area, and that is the discriminative sensation of the oral and facial region. So you know if fingers are touching your face or if a makeup brush is touching your face, along with the textures of the food in your mouth. The mesencephalic nucleus is responsible for the proprioception of the oral and facial region. So you know if your mouth is open or closed. The spinal nucleus of the trigeminal nerve is going to be responsible for, of course, pain and temperature. Motor nucleus is going to control the muscles of mastication, so like the buccinator. And all of these will terminate in the ventral posterior medial nucleus of thalamus. Cranial nerve will rest right on this pyramidal structure called the petrous part of the temporal bone. The ophthalmic division goes through the superior orbital fissure in order to innervate the eye. The lacrimal, frontal, nasociliary, anterior and posterior ethmoid nerve, the long ciliary, infratrochlear, and sensory root will all pass through the ciliary ganglion. And the sensory fibers will carry the sensation from the cornea, the ciliary nerves, and the iris. And the mandibular part will pass through the foramen ovale. The maxillary division, however, will enter through the foramen rotundum, and that will provide the sensory supply to the mid third of the face, so right around here. In the pterygopalatine fossa, it's going to be controlled by the zygomatic nerves, the infraorbital nerve, along with the posterior superior alveolar dental branches. So these are going to innervate the teeth. You're going to feel cutting sensations of the gums if you floss too hard, and you can also feel the pressure when you start chewing. The pterygopalatine ganglion is going to be where the greater and lesser palatine nerve synapse, along with the pharyngeal branch, the nasopalatine nerve, and the posterior superior lateral nasal nerve. The mandibular nerve is going to have two divisions. The anterior divisions, where it controls the temporal mesenteric nerve to the lateral pterygoid, along with the buccal nerve. And the posterior division is going to be the inferior alveolar nerve, the nerve to the mylohyoid, the lingual nerve to the tongue, auriculotemporal nerve, and it's going to connect to the submandibular ganglion. And all of that is kind of like described as the chorda tympani. In the sensory aspect of the mandibular nerve, it's going to innervate the buccal, the inferior alveolar, lingual, auriculotemporal, and spinous nerves. The motor branches to the muscle of mastication, which are going to include the mylohyoid, the anterior belly of the digastric, the tensor tympani, and the tensor veli palatini. Tic douloureux is going to be an idiopathic intense facial pain, and is usually like unilaterals on one side of the face, and it worsens over time, and it's more in women over the age of 50. Cranial nerve number 6 is going to control the lateral rectus. It lies in the somatic motor area above, or at the pontomedullary junction above the pyramid, and it will run through the cavernous sinus below the internal carotid. And in a palsy of the abducens, there's no abduction of the eye, so there's going to be medial strabismus, and it's usually caused by an increased intracranial pressure because the nerve runs alongside the internal carotid. Cranial nerve number 7 is going to have the main motor nucleus, which lies in the reticular formation of the lower pons, and then the upper face has the fibers from both cortices, like upper and lower motor neurons. The lower fibers are going to decussate, so they're decussate below the medulla. That's why it will innervate the opposite lower face, while the upper motor neuron is going to be ipsilateral. The parasympathetic aspect is the suprasalivary and the lacrimal nucleus, so this controls like tears and salivation. The nucleus of the tractus solitarius is a sensory nucleus, and it lies close to the motor tract. Those go to the geniculate ganglion, except for the motor nucleus. Okay, so in the canal, or the auricular temporal canal right now, it's going to host the internal acoustic medius and gives the nerve to the stapedius. That in turn gives a branch to the greater paratrorsal nerve, which innervates the lacrimal gland and the mucosal lining, the nasal cavity. And the chorda tympani nerve is going to supply the parasympathetic sublingual and submandibular salivary glands and the gustatory sensory fibers to the 2/3 of the tongue. In the parotid, the facial nerve will like pass through the parotid itself and split to the posterior or belly of the digastric, the stylohyoid, and the posterior auricular nerve. It forms a plexus with everything, and that includes the temporal, the zygomatic, the buccal, marginal, mandibular, and the cervical branches. If cranial nerves 6 and 7 are not working together, there's going to be a lesion in the pons. And that's going to result in the paralysis of the face and a medial squint. So the medial squint is from this cranial nerve number 6. Paralysis of the face is due to cranial nerve number 7. So if cranial nerve number 8 and 7 don't work, there's going to be a lesion usually in the inner ear, and that involves the nerve to the stapedius. In these patients, there's going to be like hyperacusis, which is where sounds are too loud, too intense. There's a loss of taste, and there's a lesion in the chorda tympani, and a swelling of the nerve in the canal is going to cause the Bell's palsy. In an upper motor neuron lesion, there's going to be spastic paralysis, and that only affects like the lower face. Cranial nerve number 9 is going to come from the medulla oblongata, and in particular the nucleus ambiguus. So it's the main motor nucleus deep in the reticular formation, and it innervates the inferior salivary glands. The nucleus tractus solitarius is going to be your sensory nucleus, and that's responsible for taste, secretomotor, sensation of the tongue, and the carotid sinus impulses. The spinal nerve nucleus of cranial nerve number 5 is going to be where the afferent info about sensation enters the brainstem through the superior ganglion of the glossopharyngeal nerve, but it ends in the spinal nucleus of the trigeminal nerve. The visceral motor afferent, or the parasympathetic innervation of the smooth muscle, is going to form the pharyngeal plexus. Oculomotor is going to be the stylopharyngeal nerve, and the general sensation is going to be responsible due to this afferent system. Cranial nerve 9 is going to exit from the post-olivary sulcus through the jugular foramen, and is going to run down between the ICA and the IJV, then pass between the superior and middle constrictor of the pharynx. The superior and the inferior ganglion will lie on the nerve as well, and those lesions are rare because it usually has to involve the vagus nerve as well. There's the pharyngeal, consular, and lingual branches of the glossopharyngeal nerves, and it supplies all of this. Jacobson's nerve is the main nerve to the tympanic plexus. The carotid sinus nerve is called Herring's nerve. So you're going to test the cranial nerves by palate raising, tongue deviation, tickling the back wall of the pharynx to contract the pharyngeal muscle. Coughing, however, in the examination can increase the pressure in the carotid sinus, which can inhibit the heart. And in patients with hypersensitive carotid syndrome, they're going to faint. And the chances of you can also get glossopharyngeal neuralgia. Cranial nerve number 10 is the nucleus ambiguus, that's the main motor nucleus. The parasympathetic nucleus is going to innervate the heart along with a bunch of soft tissue organs, and it lies it makes up the longitudinal muscles of the larynx, the pharynx, and the soft palate, and it's the nucleus of the tractus solitarius. Gustatory fibers will enter through the inferior ganglion of the nerves, which are the primary afferent from the viscera, and the afferent information of the common sensation will enter the spinal nucleus of cranial nerve number 5 through the superior ganglion of the vagus. That will arise through the post-olivary sulcus and leave through the jugular foramen. The superior sensory ganglion is going to lie in the jugular foramen, and the inferior is going to lie below the foramen. That descends into the carotid sheath, and then eventually becomes the recurrent laryngeal nerve, the superior laryngeal nerve, and the auricular branch. A lesion will cause pharyngeal dysphagia if it involves this pharyngeal branch. This person is also not going to have any gag reflex, and there's a uvulation. There's going to be a deviation of the uvula to a contralateral side. In the superior laryngeal nerve, block injury, there's going to be voice weakness, and if the recurrent laryngeal nerve has been damaged, there's going to be hoarseness, dysphonia, aphonia. Some people aren't even able to produce any noise, and inspiratory stridor. All of these can cause some form of tachycardia or the cardiac arrhythmia. Cranial nerve number 11 is going to start from cranial nerve root and the nucleus ambiguus, and that goes all the way up to innervate the larynx and the pharynx. The spinal root is going to lie within the spinal nucleus of the upper cervical segments and innervate the it's going to innervate the subclavicular mandible and the trapezius muscle. I'm sorry, it's the sternocleidomastoid. Sorry, I'm tired, okay? These enter the cranium through the foramen magnum and it leaves through the jugular foramen. You test this by asking the patients to shrug. Okay, so cranial nerve number 12 is going to be the motor nucleus closest to the midline below the floor of the fourth ventricle, and you receive the cortical nuclear fiber from both hemispheres. So it's going to innervate the genioglossus from the opposite hemisphere. It emerged between the pyramid and the olive, and it's going to exit through the hypoglossal canal, and it runs between the ICA and IJV, crosses the external carotid artery laterally, and deep to the mylohyoid. So it's a pretty protective nerve. It supplies all the tongue muscles and the infrahyoid muscle, allowing swallowing reflex to occur. And you test it by asking the patient to stick out their tongue and seeing if there's an obvious deviation. In a supranuclear lesion, the tongue will deviate to the opposite side due to the upper motor lesion. There is going to be all muscles except for the left genioglossus muscle. That's the only one that's being paralyzed. In an infranuclear region, it's usually due to some nerve injury, and the tongue will deviate ipsilaterally to the lesion. The lower motor neuron lesion, there's going to be paralysis of all of the muscles. So this is the most dangerous. Okay, so this is how you test it. You kind of have to memorize these. They do help you in your clinics when you're interacting with the patient and helping to memorize all the cranial nerves. That's it for now. Thank you for your attention and good luck studying.